Good evening, everybody. It's a session of ward rounds today, and we had a very interesting case of small bowel fistula. Nikita is going to give you a brief history of that. As you know, ward rounds are basically designed to help people learn and analyze post-operative issues. And you cannot have a bigger post-operative issue than a fistula after an operation. So even though a part of the initial presentation will sound to you as if it is a workup of a patient, please understand that it is actually a post-op workup leading to workup of resurgery. So in that sense, this case fits into the pattern of ward rounds very well. And I now call upon Nikita to give us a brief history. And then I will raise some important issues as to what are the things that we should be focusing on when you have a difficult, challenging problem like this. Over to you, Nikita.
Thank you, sir. Good evening, everyone. This is a case of small bowel fistula. The patient is a 35 years female. She is homemaker and resident of Bangalore. She's a known case of epilepsy, is on treatment. She has a history of neonatal surgical intervention. Patient has no clear details regarding that, probably bowel obstruction. She has history of 3 lower segment cesarean section and 1 open appendicectomy. Patient had complaints of abdominal discomfort and heartburn 1.5 month back. It was sudden in onset and was progressive, for which she took antacids as prescribed by the physician, but it did not help. She has a history of constipation. There was no history of any pain or fever initially. The next day, she started having vomiting and got consulted, for which an ultrasound abdomen was done, which showed dilated bowel loops with sluggish peristalsis.
Nikita, one second. Just clarifying that all this happened in another institution. Please go on. Yeah.
Ultrasound was suggestive of bowel obstruction. So patient was conservatively managed by Ryle's tube insertion and bilious fluid was aspirated. She was feeling relieved. This was all done in a daycare level, but symptoms did not subside. They have started recurring. So the patient was admitted. CT abdomen and pelvis was done, which showed dilated jejunum with abrupt transition in the proximal ileum, suspecting stricture at previous card site adhesions, possibility of adhesions, and there was minimal ascites. So the patient underwent laparoscopy, which was converted to open adhesiolysis, ileal resection, and repair of serosal tears in other institute. Post-operatively, patient had abdominal pain and distension, fever. Patient was not good. She was not mobilizing well. She did not pass flatus or stools till POD 5. So repeat CT was done then, which showed collection of in the left side of abdomen with multiple air pockets and minimal contrast extravasation and dilated jejunal and ileal bowel loops. So the patient was moved to the other hospital as per the attender's request, and a drain was placed in the second institute, which showed bilious output. So patient underwent an emergency exploratory laparotomy, and they found a rent in the bowel wall, which was repaired, and 2 drains were placed. No definitive procedure was done then. So post-operatively, patient recovered, started moving bowels, but later developed discharge from the drain sites after they were removed. She later started fecal discharge from the midline incision site. Patient landed up with enterocutaneous fistula at umbilicus region. She was conservatively managed by colostomy bag, total parenteral nutrition, and correction of metabolic complications. She was then planned for definitive management in our institute.
Yeah, we inherited the patient at this stage. All right. And so you can see that the patient basically had 3 colostomy bags. This was on the main wound. For perhaps reasons of modesty, they have covered her up everywhere else. But she had 3 bags, ostomy bags, and one was spewing out fairly solid ileal or small bowel contents in a bag like this. The 2 drain sites also had bags. This was from the time the drain was still in place in the previous institute. I just borrowed this picture from that gentleman, from the previous surgeon. This is a urinary catheter, as you know, and there are 2 drain sites. Both of them have bowel contents. And the third one was a bag. When we inherited her, she had 3 bags sitting on the abdomen, each of them putting out small bits. The lateral ones, the so-called drain site ones, putting out small amounts, and the fistula from the main wound putting out about 50 to 60 ml per day of bowel contents. Okay, so I will go to the concerns later, but there is a good question from Ravi Shankar sir. What are the likely causes of... Okay, there are some answers also there. Okay. Neonatal surgery, yeah, likely causes of obstruction needing intervention. Okay, congenital band, small rotation, intersusception. Neonatal is not very common. Necrotizing, okay, intestinal malrotation, somebody has mentioned. Atresia is another one that you must add to that list.
Yeah.
Atresia.
Jejunal atresia.
Okay, that is something you must add to that list. And that's a fairly complete list. So let's move on to this. And when you get a case like this, there are certain concerns. Okay, so starting with the junior most. Praveen there? Yeah. Praveen.
Yes, sir.
Yeah.
Yes, sir.
Tell me, what are the things that would concern you? What aspects of patient care should you prioritize?
First, we should check about the nutritional status, sir.
All right.
And if there is fever and derangement of blood picture, then should look
how
out
you
for
diagnose
sepsis.
these things, we'll see. So what you're going to say is, you have mentioned 2 concerns now. Nutritional status, correct. Sepsis, correct. Anything else? How you diagnose this will come to later, but as a surgeon, when you inherit a problem like this with 3 holes spewing out bowel contents, you look at nutritional status, 6 weeks of history. Remember, we got her 6 weeks after the first laparotomy.
So first laparotomy, they did this one. They did bowel obstruction.
Bowel obstruction, adhesiolysis, and laparoscopy they did to start with. All right, and they felt that going was tough, and so they converted it into open, did adhesiolysis, and in the process, they had some serosal tears, which they stitched up. But then she had a leak, basically. Yeah. She had a collection. So she was then shifted to a second institution where that surgeon initially drained that collection, found it was bile, and then opened her up again and found a rent in the bowel, in the jejunum, which he sewed up, gave a washout, put a couple of drains and came out. Then after that, she started spewing bowel contents in the 2 drains as well as from the middle part of the wound. Yeah, and from the midline wound. So Praveen, you're right. You mentioned sepsis, you mentioned nutrition. What else?
Fluid and electrolyte balances, sir.
Okay, fluid and electrolytes. This is an important thing. When you have small bowel, particularly if it's more proximal, okay, then you have to be very careful about what happens to the skin, because the more proximal it is, a duodenal fistula, for example, spews out a lot of pancreatic juice, bile,
severe,
and it excoriates the skin in no time, and that itself will become a source of bad sepsis. So, but these are the four things that you really think of. This patient had fever, mild sepsis, but no organ dysfunction. Her creatinine was normal. Her LFTs were slightly deranged. She always ran a fever of about 100 degrees. Skin was normal. Nutrition was poor. Her size looked normal, but she was edematous because of a chronic sepsis. Nutrition was poor because her hemoglobin was in the 10 or so range, and her albumin was low. Okay, it was not frightfully low, but it was 2.8. I can't remember the exact figure, but the albumin was low, and she had significant metabolic issues. Okay, so what are the metabolic issues that she may have? Nikita.
As it is a small bowel fistula, she would be having hyponatremia and hypokalemia, sir.
I told you that her fistula output, how much did they say was the fistula output? Did you notice that? Did you hear that?
Yes, sir. Around
60 ml.
60 ml in each train.
Yeah,
Yes.
there were very little in the two lateral bags which were sitting there, and 60 ml a day coming out of the wound. It was, and so with an output like that, would you expect gross metabolic disturbances?
Not significant, sir.
Not significant. But I put it to you that she had significant metabolic disturbance. Her potassium was in the boots, 2. Potassium was 2. The calcium, for some reason, was 5.6 to start with. Very low calcium. Okay. And why would you think that would have happened?
Sir, could we attribute it to the neutral status rather than the metabolic derangement caused by the fistula, sir?
Right. What do you mean by nutritional status? I think you know the answer, but you have not put it correctly. All right. Who else is there? Vinod is not in. Is he here? Vinod?
Hello, sir. Hello, sir.
So, what do you think? If it is not the output that is causing this metabolic disturbance, what else can cause metabolic disturbance?
Intake, sir.
Thank you. Correct. All right. That's what perhaps Nikita meant, but it's actually the way her nutrition was managed in the past 6 weeks that can give you huge changes. Okay. Abnormal loss was not one of the factors. So when you see a patient like this, the next thing is correction of each of these. Okay. We covered her with an antibiotic, and to direct that antibiotic treatment, what would you be looking for? Previous culture and sensitivity reports from any of these. Okay. And she didn't have any specific indication. So we used tazobactam and piperacillin to cover her, but she was not ill with sepsis. As I said, she did not have organ failure. So until we got that, so we got some fresh culture swabs taken, covered her with a broad spectrum antibiotic. Skin was not a problem. And we recommended that we admit her and give total parenteral nutrition because we wanted to rest the bowel completely. Okay. So patient refused to get admitted perhaps because of financial conditions, and the previous surgeon said he would somehow manage the TPN, even though I had a lot of reservations about it because metabolic issue was there. I had to accept that he would do what he wanted to do, and he did all that. And when you are advising him nutritional support to bring it up to speed, how long would you give it as a minimum? Nikita. Multiple choice. 2 days. 5 days,
minimum
7
of
days,
7 days,
10
sir.
days. Yeah. All right. I would buy that. You need to give it for a minimum of 7 to 10 days. So I recommended a 10-day total parental nutrition. And you would, with a ileostomy or not a stoma, it is with a leakage from the middle of the wound being 50 to 60 ml, would you think of anything else other than nutritional support? Something which would avoid an operation? That will bring me to my next concern, but I'm just asking you before I change the slide. This is the question. Okay. I gave you a direct hint to say, what would make you have to operate? Or would you even try a conservative treatment for intracutaneous fistula, hoping that it would close spontaneously? Vinod.
Hello, sir.
Yeah, did you understand my question?
Sir, conservative management basically, sir.
Correct.
Sir,
Conservative management with a hope of not having to operate again.
yes, sir. Sir, low output, sir.
Correct. So by definition, what is a high output?
Greater than 500 ml.
Correct. Okay. There is some people consider an intermediate output also. And what is that level?
200 to 500.
300.
Yes.
High is 500, intermediate is 300, and less than 300 can be considered low output. This is 50 to 60 ml. So definitely it was a low output fistula. Go
Yes,
on.
sir.
What other, is that the only criterion or the other criteria?
There should not be any blockage in the distal end of the fistula.
Right. Very good. No distal obstruction. Yeah.
And epithelialization is one of the cause for delay in.
Yeah. You wouldn't know epithelialization, when you look at the wound itself. Yeah. Okay.
And size of the fistula, sir.
Size. You mean the diameter of the hole? No.
Indirect length, sir.
Length. What do you mean by the length? You're getting there, but that's not the correct answer.
End or a side.
Yeah. So anybody else to add? Sanya?
Sir, underlying malignancy would not allow us to close.
Underlying disease, not just malignancy. Malignancy is one of them. Tuberculosis, Crohn's disease, it won't heal.
Yes.
Yeah, I mean, unless
Yes.
you treat.
Radiation.
Yeah, radiation enteritis, unlikely to
Yes.
heal. So underlying disease, correct?
Distal
That
obstruction.
should come first. Yeah, Vinod mentioned it.
Nutritional status.
This is the important thing. So if you have a hole in the bowel spewing something, okay, and when you said length, we know I presume giving you a lot of benefit of doubt that you meant the distance of the bowel from the abdominal wall. All right.
Yes. Yes.
So if there is an intervening abscess cavity from the hole in the bowel, between the hole in the abdominal wall and the hole in the bowel, there is an intervening abscess, it won't heal. Okay.
Sir, is there anything related to the site from which the fistula is arising that could prevent
site?
its process?
No,
Yes,
Ravi mentioned it, right? And if it's coming from the end of something, it won't heal.
No, so
If
the bubble, I mean.
No, there is no direct relation for that. Yeah. Okay. So these are the disease, these are the conditions, and of course the nutritional status and the other general conditions like any healing, okay, sepsis and things like that. That is given. So first of all, as soon as the patient came, I said you need nutritional support. So I wanted to find out all these issues, whether these were there or not. Okay, so what should I do next? Is giving nutritional support only enough or something else has to be done? quickly. I mean, it's all common sense. There is no rocket science in this.
In her case, antibiotic therapy is also required, sir.
Yes,
along
we said that antibiotics were given, nutritional support was recommended, not under my direct control, but it was recommended. Yes. Anything else? I said, how do I know each of these things? That is the question. How do I know that there is no? We know about low output. It is very clearly. It was obvious on the outside.
CT.
Yeah. Okay.
evaluation.
Yeah. Only CT, or would you do something else before that?
With contrast.
Okay. Yeah. You would actually do an ultrasound also. Okay. Which would tell you if there are any collections. If so, where are the collections? And
So that
then
we get to know by CT also.
sorry?
That we can get to know by CT, no, sir. At once can't we
No,
directly get to CT?
yeah, I'm glad you raised that issue, because CT may not give you all the collection in all the places, unless it is a big collection. And you all can also it can tell you more about the bowel, its distal obstruction, possibility of underlying disease. All this CT can tell you, but it cannot really define. You will find a hazy shadow somewhere in the interloop area. Is it an abscess, or is it just a bit of inflammatory reaction? So if it is an abscess, it's fluid, and an ultrasound will show it up very well.
So ultrasound is more sensitive to detect
in these fluid collections. So I would say both are complementary. Only one of them would be inadequate. Right? So we got an ultrasound done. We didn't show any intra-abdominal collections. We got a contrast enhanced CT, which showed no underlying disease, no distal obstruction, and no intervening abscess. All right.
Sir, and the now whatever this thing she has, the output she has, we'll be sending for culture sensitivity, no, sir?
Yes.
Keeping in mind that TB is the most common, like could be an underlying TB. AFP, sending an AFP would help.
No, it wouldn't, because contents won't tell you that. It won't tell you
then
that.
We have to. How do we rule out TB, sir?
It is very difficult to rule out TB unless you took a biopsy from the edge of the hole in the abdominal wall. Okay. If I were continuing with conservative disease, conservative treatment, I probably would have considered that. But even though all these things were not there on ultrasound and contrast enhanced CT, purely because of financial issues, I decided to go in and operate and close that hole. All right. So that brings us to the point.
Sir, what about duration, sir?
Yes. Which one?
The
duration
of fistula.
Yeah.
And we have tried this conservative management for around.
It's now 6 weeks, 5.5 weeks.
So if it is generally, if it is greater than 6 weeks, can we go for a surgery, sir?
Yeah, I'll come to that. I was going to raise that issue, but you have asked. I'll come to that. Before I go to that, I would like views from Ravi Shankar and Niranjan about doing both ultrasound and CT for these cases.
Sir, I agree with you that, I think like any investigation, if you start with an ultrasound, I think it will definitely give us idea about subphrenic collection, all these interloop abscess, all those things it might tell you. And then CT obviously will give you the anatomy. And you can add if you want to do an enteroclysis or a fistulogram, as Abdul was suggesting. Yeah. You can even do a fistulogram to identify where the fistula is actually coming from also. Yeah. I think there is this one acronym for management of the fistulas. SNAP. S is sepsis, N is for nutrition, A is anatomy, and then P is for plan. So we can plan the surgery based on all the three of them.
So I think. Sorry, go on.
Yes, sir. Yes, sir.
You would agree with that. Okay. So I said that I decided to operate based on financial issues. So what are the things that influence the financial issue? Vinod, tell me yourself.
Prolonged hospital stay, sir.
Yes.
And nutrition.
Yeah, TPN, total parenteral nutrition.
Yes.
And the fear of worsening sepsis.
Yes.
Okay, even though she had no organ failure, she had low-grade fever, high white cell count, but stable with antibiotic cover. And so, if you're looking at TPN as one of the factors that can, impact the finances, what is the kind of cost that you're thinking about? In other words, how long do you have to give TPN in these patients whom you hope will heal the fistula spontaneously? And what are the chances of healing?
Sir, generally in low output fistulas, I think we can start, if there is no distal obstruction, we can go for enteral feedings.
Enteral feeding? You mean distal to the fistula?
If it is low output, I think we can start.
Yeah, you can use elemental diet if you can, not easily managed. This was somewhere in between, all right? From on the CT, it showed that it's somewhere between jejunum and ileum. So you have equally divided bowel. You can't feed from the top. You can't feed from below. You can't feed distal to the fistula. And I can tell you that to meet 100% requirement of these cases who are malnourished, it's very difficult. With
distal access was not possible, sir.
Not possible because it was somewhere in the middle. And you wouldn't have enough length of bowel either way.
Cannulation distally was not possible.
We didn't even try it because we didn't have enough length of the bowel. The hole was somewhere in the middle of the bowel. And there was always some degree of obstruction. It was not in the sense total obstruction, but there were dilated loops of bowel. It could be either little pockets of obstruction because of the previous adhesions, or it could be ileus also. It's not easy to say what it was, but the gut was not available for feeding, so we had to give TPN. That was for sure. So, what kind of healing would you expect if you give TPN? In addition to TPN, what else would you do to help the fistula heal? These are two simple questions, practical questions. Any answers? You had time. Sanya, did you read up about it?
I did, sir, but all that about healing, it was just to maintain the nutritional status, to improve the patient's nutritional status.
You can expect, when all the conditions are favorable, you can expect about 60 to 70% of these intracutaneous fistulas to heal within about 6 to 8 weeks. That is the ballpark figure. Different series will give you a slightly different data, but remember this, 60 to 70% heal in 6 to 8 weeks, which means we can't do home parenteral nutrition here. I had to keep her in hospital for 6 weeks, give her TPN all these days, or that much of hospitalization, plus accept a 30% failure. After all that, if she is not better, then you have to operate. So for practical purposes, from my experience, in fact, in the whole of my career, I have treated only 2 patients for that length of time with TPN. One of them it failed, one of them it succeeded. In all my 30 years of practice, most people in this country end up with surgery. So you give them a week or 10 days of TPN, build them up a little bit, control the sepsis, and go for surgery.
Sir,
okay, go on.
Don't you have to weigh that against the risk of difficulty of access into the abdominal cavity and further damage to the bowel and possibility of more damage or fistulization, all these things, because if it will probably the worst time to go in these situations.
No, this is already 4 weeks old.
Yeah, but still because of the sepsis and collections that had happened and all the previous.
That brings us to this question. We'll put it to the students first, and then I'll go by what we'll take your view. When would you operate? First, in a patient with fistula, when would you operate?
Sir, one doubt I had related to previous this thing you told, sir.
Okay.
That it takes around 6 to 8 weeks for them to heal.
Yeah.
During that time, when do you shift the patient from TPN to oral and then maybe liquid to solid diet? If
Yeah,
you are
you
considering.
don't, as long as there is fistula, you do
Yes.
not give them solid diet
Yes, sir.
at
The
all.
liquid diet
And
as tolerated.
but that too, no, please note this. In this
Yes.
particular patient, for example, I put it to you, it was a fact that it was somewhere in the middle. You could neither
Yes, sir.
give, there wasn't enough length either way. Okay, if there's a proximal jejunal fistula, you can put a tube to the distal jejunum and start feeding. If it's
Yes,
a
sir.
distal ileal fistula, you can either put a tube into the stomach or into the duodenum and give them, or even oral, you can give them elemental diet or very low residue diet and see what happens. But in this particular patient, you had to give them total parenteral nutrition, give her TPN until the fistula healed, until the output became zero. There's no doubt about
So
it.
if you're considering 6 to 8 weeks of healing, suppose in this patient, sir, if
Yeah.
not considering the surgery part, 6
Mhm.
to 8 weeks of TPN, sir.
Yes, that's what I'm saying.
Okay.
That's why
Okay,
it was financially not viable.
Okay, sir.
Okay, Nikita, you have raised your hand.
Sir, my question is role of nasogastric tube in this situation, sir. Do we need to dry out that fistula, or should we just let it flow on, sir? Because there are two different ways of management.
Mhm.
One being drying it out using proton pump inhibitors and all to decrease the secretions using octreotide and fine. But the
Excellent.
other,
If you remember, I'd asked that question, but I hadn't waited for you guys to answer. I had said, would you give only TPN or do something else? Okay, you've just answered that question. You have to give them PPI. You have to give them octreotide. What are the roles of these two?
they decrease the gastric secretion, sir.
PPI decreases gastric secretion and octreotide,
Pancreatic.
pancreatitis, pancreatic and
Pancreatic secretion.
succus entericus. That brings us to the physiology. How much of gastric secretion do you think you have?
2 liters, sir.
Hey,
1.5, maybe 1. Okay. And how much of pancreatic secretion do you have in a day?
2.5.
2.5 pancreatic?
succus entericus is, but
Yeah.
not pancreatic.
Okay. If you read the GI physiology in current surgical diagnosis and treatment, it gives you a beautiful picture. It is 4 liters proximal to the ampulla of water and 4 liters distal to the ampulla of water. So it's 4 liters from saliva and gastric secretions. It's 4 liters of bile, pancreatic juice, and succus entericus. Okay. So if you put out 200 to 300 ml of fluid in your feces, you can imagine the amount of reabsorption that takes place in the intestine, small and large intestine. A lot of water is reabsorbed in the large intestine. So you have to reduce the gastric secretions through PPI, reduce pancreatic and succus entericus through octreotide, which she received. In fact, she didn't, because again, octreotide is expensive. And so she had some concerns with that. And so we recommended, but she didn't take it. So the question is, when would you operate? So a patient comes to you not completely in sepsis. There's still a low output fistula. And even though theoretically that fistula can be managed conservatively and see if we can allow it to heal, because of socio-economic reasons, we decide to operate. When would the timing be? In fact, I put this question and Ravi Shankar has already raised a valid question. So for the students, let's
just out of interest,
Hmm.
on those 10 days when you had recommended the TPN, what happened to the output?
Same output, no difference.
No difference.
No difference.
Did she ever have anything orally to take? And
sips of water to wet the tongue and nothing beyond that. That
no,
was a
that
recommendation.
not when she came to you. Before that, when she was with after the second surgery.
Yes.
When she was taking orally, what was the output then? Did the surgeon tell you what was the output? And
yes,
then
it was it was about 100, 150 ml, and it came down to 50 to 60 after she became NPO.
Okay.
And that NPO was for a short time before she came to me. And she went into strict NPO after she came to me, but still not under my direct care, as I mentioned.
Sir,
So when would
one
you...
doubt.
Yeah, go on.
One doubt. I had missed the initial part. What was the surgery done initially? I had missed.
It was a laparoscopy bar laparotomy converted to laparotomy for intestinal obstruction.
Okay, post that enterocutaneous fistula.
Correct.
Okay.
Ideal
And
dissection
any specific reason why elemental nutrition, that elemental diet was not tried at least for 1 or 2 days to check the output?
Her nutrition
along
was,
with TPN.
No, her nutrition was not checked at all.
Okay.
Okay, earlier. I mean, she had some things, but on an ad hoc basis. And when oral things were, when it increased the output or it was higher, then the previous surgeon also gave TPN on an ad hoc basis, not the full requirement each day. And it brought down the fistula to about 50, output to 50 to 60 ml. And I recommended a proper full 2,500 calorie, 60, 70 grams of protein, TPN, and that she had for 10 days. Elemental diet was not tried at all. At any time, even I didn't recommend it, because at that time, because I knew that you could not wait long enough to get the fistula healed spontaneously. I had decided that I would operate in 10 days' time, and I built her up with a TPN.
Okay.
Sanya, your hand is up.
So previously, ileal dissection was done, sir. Any availability of that HC report if there's underlying Crohn's?
Yeah, no underlying disease.
Okay.
No underlying disease. Abdul.
Yes, so my same question, that intestinal obstruction, what was the cause, the first intestinal obstruction?
We have to take it as adhesive obstruction.
Okay.
Nothing beyond that. Okay, so when would you operate? I had, Ravi had raised a question. Would it not be difficult to operate technically when you do this? The answer is yes. But any other views from students, from registrars? It's unfair to ask postgraduates. Registrars.
So any abscesses has to be drained.
She's not terribly septic. There are no abscesses, both on the basis of ultrasound and CT.
Any, sir, if it is Crohn's?
No underlying disease.
Underlying disease.
From the previous section, no underlying disease. Niranjan, when would you operate? Are you there, Niranjan? Okay. So, Ravi, to answer you, I had to bite the bullet and operate on this patient. Because if I waited another 3 to 4 weeks, the adhesions would get better. The downside of that is that sepsis may get worse, but then you can argue, you can go in whenever it gets worse, you keep her under close observation. But the main point is that we could not sustain her economically, her nutrition and her metabolic status.
Yeah.
So I decided I have to operate on her. And the best I could do was wangle. I had to negotiate. In fact, he said, sir, 3 days, sir, 5 days of TPN. I said, no, 10 days. And don't ask me for anything else, because I can't afford to fail again. And I may, if the nutrition is not good, and I was doing the third operation on her. So we wangled and said 10 days, and we decided to operate. And sure enough, technically, it was not easy. But yes, what are the principles of surgery? This is where I come, and I'm going to discuss what we do when the going gets very tough. We will do that. We'll discuss that. But okay, Abdul, come out with some principles of surgery here. What are the principles that you think of?
Sir.
Yeah.
Sir, just
go on.
Just as a devil's advocate.
Yeah.
I would say, see I agree that there is always that Damocles sword of sepsis hanging over her. That there is no doubt. But the CT scan has shown no abscess cavity in between the fistula and the abdominal wall, and there is no underlying disease. And you have done a good job in giving a TPN for a period of 10 days.
Yeah.
Then the fistula output has never been a major issue. as you said, apart from the fact that she had low calcium and low potassium, which you corrected.
Yeah.
Let us just accept 100 ml and then, allow her to maybe give her an elemental diet, wait for 6 months and see whether it will actually heal on its own.
Yeah.
And then if it doesn't, then, you have to warn her, obviously, that it may not work. If it does, then it's your luck. If it doesn't work, then 6 months' time, the fistula, the abdominal cavity would have probably reformed, and then it would probably be easier for me to operate.
Yeah. Elemental diets are expensive. And they're not easily
I agree
managed.
with that.
Yeah. I had not with an elemental diet, I must admit, but with a low residue diet. There was an experiment done by the previous surgeon, and it had increased the fistula output. So I didn't want to try that again. I thought of, but again, did not think of, did not even consider elemental. Thought of it, but didn't institute it at all because of financial issues. And at this point in time, everything becomes a difficulty. They couldn't manage at home. They couldn't manage these bags. There were 3 bags. They couldn't manage it at home. And, they can't be even in the other nursing home. They could not be. Even that is expensive, if not, bigger hospital.
Absolutely, I agree.
So what was driving me was basically the socio-economic status.
Yeah. And the other thing is, what is very glad is the fact that somehow they have managed to maintain this integrity of the skin.
Yes.
Which is excellent.
That was a very good thing that happened. So what are the principles of surgery, Abdul?
So the surrounding skin quality.
Skin was not a problem.
Okay. And then the sepsis, whether underlying all that sepsis, nutrition.
Correct. We have managed that.
Yes. And no distal obstruction.
All right. We have said that.
Yes.
This is a recap of whatever I said, but these are the principles. Okay, very good.
Gentle handling of the remnant bowels.
Yeah, okay. Remove all disease if there is disease. This patient had no real disease, but if you had a bit of tuberculosis or cancer or Crohn's or something, you must take out the whole segment. And anastomose healthy bowel. And
look at the vasculature, sir, of the bowel.
It's given that it's vasculature.
Young girl.
Yeah.
With no disease. Shouldn't have a major issue with vasculature.
Sanya, your hand is up.
Sir, you say CT was done for her, no, sir? I don't know if I missed, but did it mention about how many fistulas are there, like a complex fistula or just a single?
No. It wasn't very clear. What it said was that there was a matted loop of bowel with segmental dilatation just under the skin and extravasation of dye.
Okay, sir.
Nothing beyond that.
Yes, sir.
And
so one more question.
Go
on. Given the medico-legal aspect of, if we consider, sir, can socio-economic status would be enough to decide that he went ahead with surgery?
Absolutely. Okay. Nobody can say you have to spend millions and get somebody right without surgery. Nobody can say that. There's absolutely no, I was about to ask this question and it has already been asked by Abdul. Okay. So he says, when would you consider a fistulogram? You tell me, Abdul, yourself. When would you consider a fistulogram?
When you said no, so there's a matted, like a lot of bowels.
Yes.
And exact definition of what segment you couldn't identify.
Yeah.
In a fistulogram, we better delineate the segment.
You can't. You can't really say whether it is ileum or jejunum or where it is. You may sometimes say whether it is large bowel or small bowel. Okay.
Yes.
When you would really do is that if you don't have extravasation of bowel somewhere, okay. you have given contrast enhanced CT you have done. It shows bowel loops of bowel filled with dye, but you don't actually see extravasation. So where is this bowel content coming out from? Okay, that is when I think a fistulogram is a must. So when you put a fistulogram, it may be going tracking somewhere else, away from where the actual external opening is. But here, under where the fistula was, under where the bag was, there was a matted loop of bowel, mass of bowel, with extravasation in the same area. So we had very little doubt that that was the issue. The only doubt was where was the fecal matter coming from to lateral drains? Were there fresh holes or not? Was the question. Okay, and that we decided we need not do a fistulogram from the both sides. We will explore it and see when we are actually decided to open. When we open, we look at everything. And so that's what we did. Maximum calcium is absorbed in proximal small bowel. Okay, that's fine. So what are you trying to say there?
Patient had hypocalcemia, no, sir.
Yeah.
So usually proximal bowel resection causes hypocalcemia.
There was no resection. There was no short bowel in this patient.
Previous rent. Sir.
Even then, previous rent also, it was a very small rent and they just...
fistula, no, sir, the loss of fluid before absorption.
There is no loss. That's what I'm trying to tell you. The loss was 200 ml to start with and came down to 50 ml by the time the patient came to me.
Okay.
Okay. So it was, in fact, I still haven't explained why there was such severe calcium, low calcium, and hypocalcemia and hypokalemia. Because she took tons and tons of calcium for us to correct it. That's why we then decided to give magnesium. Magnesium was low. And so we gave magnesium also to correct that. Either way, it took a long time. And in fact, after everything, after 2 weeks, after 10 days after my surgery, it got corrected just now, recently. So that is and I still don't know exactly why this happened. So I actually asked for a parathormone assay to make sure that she doesn't have some kind of a hidden hypoparathyroidism. The potassium you can explain by previous management not giving her adequate potassium.
Vitamin D, sir, I think but again, vitamin D will not cause such
severe things.
Yeah.
But you're quite right. We have, after my surgery, we have put her on vitamin D3 and calcium supplements. It has all settled down now within 10 days. But I do suspect there's something more than just hypocalcemia. We also remember hypoalbuminemia can give you an erroneous low calcium level, but that is also corrected now, and in spite corrected calcium was also low. So we were keeping a very close eye on it. So anastomose healthy bowel is another thing. Okay. And if the patient is nutritionally compromised, you can, even at that time, avoid an anastomosis and give her a stoma. Okay.
Sir?
Go on.
One more question. I think PG should answer this if possible.
Yeah.
When the second surgeon went in, was there a lot of sepsis in the abdominal cavity, sir?
There was a collection of bile in the abdominal cavity.
Yeah. So now the question is, would you, given the condition of the patient and, I think probably nutritionally already by that time would you consider, just repairing the bowel and coming thinking that you'll get away with it, or would you do something else to avoid this?
Yeah. I go on. PGs.
Nikita, Vinod, Praveen.
Yes, sir. I would go with only trying to repair the primary source of sepsis, sir. As the patient was nutritionally compromised back then during the second surgery.
Doesn't answer.
So can you hear me, sir?
Yeah, we can hear you. Dr. Ravi Shankar's question is simple. There is a rent in the bowel. There is bile in the peritoneal cavity. Nutrition is probably compromised. Would you close the hole and come out, or would you do something else?
Something else meaning peritoneal toileting, sir, or any other procedure?
Any other procedure? Anything?
We'll place feeding jejunostomy, sir.
Where? What would you do with the hole in the bowel?
Can I answer?
Yeah, go on.
So depending on the rent that is there, if it is big enough, then we would do a resection, sir.
Okay. And then would you anastomose, or what would you do?
Yes, sir. Resection, depending on the friability of the tissue or if it is healthy,
Yeah.
If it is healthy, we can go ahead and do anastomosis. But if
looks-
it seems to be tribal or
then
some
what would
underlying
you do?
disease, we have to
Yeah.
do
What-
so much.
Diversion.
So it's a different diversion.
Yeah. The simple answer, all of you are saying everything else other than what you have to say. And what you have to say is exteriorization.
Correct.
All right. You can bring it out as a double barrel ileostomy or jejunostomy, as it were, or you can just bring it out outside the abdomen so that it doesn't soil the peritoneal cavity and intubate the distal part to enable nutrition, or you can divide the two, bring out the proximal part as a jejunostomy or an ileostomy, and the distal segment as a mucus fistula, because it's a non-defunctioned bowel or non-functioning part. You got that? So you have simple exteriorization or formal ostomy formation. So those are the options. But
Yeah.
if you think that there isn't a lot of sepsis and the bowel looks healthy, you can close it and come out. And so we will give the benefit of doubt to the previous surgeon. He perhaps thought it was okay and closed it. But as it happened, for the patient's ill luck and the surgeon's ill luck, that gave way and the patient had a fistula again. That's why the patient ended up with us a little later.
What is
It's
the advantage of doing what sir said of exteriorizing, and what is the advantage? Anybody? Ayman, Sania or Abdul?
So
Just
you,
give it.
if you anastomose, more chance of leakage. So you build up the nutrition till that time. It's a temporary.
Yeah. See,
Diversion.
the advantage would be, one is you are, taking care of the sepsis. Two, you are exteriorizing the bowel, and then you are also getting access to nutrition. You can you don't have to use costly nutritional TPN and things like that. You can use your daily nutrition through the distal bowel, and then wait for as long as you want to wait, and then you don't even have to do a laparotomy, because you can just around the you can circumstomal incision, and then you are anastomosing and putting it back. So you're avoiding a lot of things if you had done that. But I think we have to respect the judgment of the surgeon who thought that it was okay to close it. So it is a difficult thing. We are all very wise after the event.
Yeah. In fact, what was the title you gave initially, Nikita?
Cost of a drain, sir.
The cost of a drain. And I think you were influenced by the letter that the previous surgeon had written, right? Did you see that?
Yes, they specifically mentioned that drain
Yeah.
was not.
Yeah. So,
Yeah.
and I have to, I'm not mentioning names, so it's completely ethical. The previous surgeon, the second surgeon, had written a letter to me saying that a mistake was made by the first surgeon by not putting a drain after he closed the rent at the first laparotomy. And so the patient leaked. I didn't say anything about it to that particular person, the surgeon concerned. But I can tell you that drains are not a must. So what happened was that after he put a drain for the second surgeon, he closed the rent and put a drain, and still it leaked. Okay, instead of in one place, it leaked in 3 places, as it were. Okay, so when I went in the last time, fortunately, it was the last time, after I dissected everything out and took out the bowel and did an anastomosis, the second surgeon was with me. He was in the operation theater, and he insisted that I put a drain. And reluctantly, I put a drain. But I am very clear that you cannot drain the general peritoneal cavity. And so the drain is a double-edged sword. If you leave it long, the drain can actually erode into the bowel itself. It can go into the anastomosis that you have made. And remember, these are adherent bowel everywhere, not freely moving. And so if you put even a flexible drain like a Romovac or even an ADK, with rigid bowel, with the movement of respiration, your drain can get into bowel or damage bowel. So I was very, very reluctant. But because the surgeon had such strong views, The second surgeon had such strong views. I put a drain in and took it out in 48 hours. Straight away. Nothing came out of it and I took it out. But please remember, drainage of the peritoneal cavity is not a must. If you suspect continued leak and collections in defined spaces like subdiaphragmatic space, subhepatic space, paracolic gutter, or the pelvis, these are the cavities, defined spaces, then you are correct in putting a drain, but take it out as soon as you can. That is an important lesson that all of us must learn. Ravi, your comments.
Yes, sir, absolutely. Don't I know that very well?
Yeah.
But I think what postgraduate saying, I think what happens is that if the drain is placed in a particular cavity and it is draining well, the cavity shrinks. So the drain automatically advances. So it will then, as sir said, erode into either the anastomosis or a piece of bowel or sometimes bile duct, vascular channels. So it can erode into any of these places. So it is all documented very well. So kindly remove the drains as soon as their job is done.
Niranjan? Sanya, your hand was up.
Yes, sir. I totally agree with drains not being placed, but one doubt, sir. These fistulas are most commonly caused post-operative, which is because of anastomotic leak only, no, sir?
Yes.
So by keeping a drain, can we not detect that leak early and intervene early than waiting for a fistula to form, sir?
Very, very good question. What intervention will you do early if you detect
So maybe
it early?
if the drain is there and we find that the bowel contents are leaking, knowing that there is an anastomotic leak,
yes,
we might go in and repair that leak, sir.
Would you need to do that? Will it work?
So like sir said, exteriorize the bowel if it is not taken off.
Would you do it in all fistulas or all anastomotic leaks?
No, sir, not all anastomotic.
So you go by metabolic condition of the patient, septic and metabolic condition. Because if you do not put a drain and come out, there is an anastomotic leak. Patient will be unwell. Patient will be septic. Okay, white cell count high, ileus, abdominal distension, looks ill. So you can very easily detect an anastomotic leak by doing a contrast study.
Okay, yes.
Okay, and so you don't need a drain to detect anastomotic leak. And the moment you detect anastomotic leak, this is something which is on par, a par for course for all registrars. I've been a registrar myself, and I have told my chief, sir, this patient is leaking, we should explore. And all my registrars have told me that, sir, the patient is leaking, please explore. Please note that if the patient is not septic, not extremely ill, there is a definite role for non-operative management of anastomotic leaks. That's a different topic, and I'll deal with it on another day. When do you have to explore? If you do not explore, what are your options? And when you explore, what are your options? All that I will, it's a topic by itself, and definitely we'll discuss that sometime. So drains are not a must. So when Abdul, hand is up.
Sir, I just wanted to know what was the intra-op finding, sir?
Yeah, I was coming to this. So these are the principles. Please note that these are the principles. And you can see that this is the operative photograph, which has the hole. It's a small hole. It allowed nothing more than the tip of my artery forceps, but it went into the bowel there. And this particular shot, you do not have the lateral drain holes. But when we actually took out the bag, and after we washed out that little feces that was coming out of those two holes, it didn't show anything else. So what we decided that we'll also explore it from the inside. Okay, and I'll show you one more photograph before I go into the steps of the operation. You can see the degree of adhesions and the way it is stuck. What I've done is gotten around the bowel. This is the bowel. It was going like this, and this was the hole. This is where we removed it from the abdominal wall, and this is the other loop. This loop is actually an adherent bowel, not associated with the actual fistulous loop. And along with the principles that I mentioned, you have to take down as much as possible all the adhesions. Here, we had to take down more than the usual amount because I had to go lateral up to that point, up to the point from where the two drains had come out. And I found that there was nothing there. And the fecal matter that was coming out of that was from a tract that was practically subcutaneous. It was not even intraperitoneal. The fecal matter had gone into the subcutaneous area and it had tracked across the sides, and then it had found that the oblique tract that the drain had taken, it had opened into it. From there, the fecal matter was coming. So there's nothing in the intra-abdominal part. So I took down all the adhesions, and this is where the important point that Ravi made comes into action, comes into an important, has an important bearing. And that is that in trying to release these adhesions, you may cause more and more rents. Okay. So when that happens, there's a simple principle. Anything more than 3 anastomosis, 3 cuts in the bowel that you stitch, has a statistically higher significance of rate of leak than anything less than 3. So what you have to do is do your best to cause no rents. And the principle there is simple. If the bowel is stuck to the peritoneum on the anterior or lateral abdominal wall, cut the peritoneum. Do not try to release the bowel from the peritoneal surface. Cut the peritoneum and have a cuff of the peritoneum onto the bowel, and you will not cause any damage to the bowel. Second, if you have a mass of bowel which is tightly knitted and the fibrosis or the inflammatory reaction makes it difficult either to cut through this tough fibrosis or makes it so friable that the bowel keeps getting a rent, do not try to undo that mass of bowel. Have an open mind to resect that bowel. Okay, and the only thing that should get your antenna up is to make sure that while doing this resection, you do not cause what? Short bowel syndrome. Make sure that you don't take so much of the bowel away that you do not cause a short bowel syndrome. So what is the minimum kind of length of bowel that you have to leave behind? You have to have that in mind before you plan your resections. Nikita.
Greater than 200 centimeters.
Correct.
If it is less than that,
that is correct. So you must learn to leave definitely as much as you can, but it should not be less than 200. Okay.
If you have the ileocecal valve, you may stretch it up to 150 centimeters. If you have the ileocecal valve along with the colon.
Yeah. That's true. So, but the ballpark figure you should bear in mind is have 200 centimeters of valve. In this case, fortunately, remember these 2 things. If you have a hard, matted, friable loop of bowel, resect everything. Resect that bit, but make sure you leave 200 centimeters behind. If it is stuck to the peritus, not interloop adhesions, peritus, take the peritoneum with you so that you do not damage the bowel. So here, at points, I had to take the peritoneum with me, but releasing the bowel was not a problem. I could release everything, go laterally, and as I said, confirm that the bowel, the drain sites were not soiled from inside, from another fistula. So essentially, there was only 1 fistula. So I resected only about 6 or 7 inches of bowel. It wasn't much. And I've turned, you can see some, in my dissection, some part of serosa is gone there. This was quite intact. This loop of bowel I could eventually release. That was not a problem. So I cut it from there to about here, and then did an anastomosis, put the bowel back, and I'm glad to say that I was lucky enough to get away with it. The patient is doing well. Questions after comments from, if Niranjan is still there, Niranjan can give a comment, and then Ravi, and then we'll take questions and further discussion. Niranjan, are you there? Okay, he's not there. Go on, Ravi, please.
I think patient has been managed very well. I think we are still not able to explain the hypocalcemia and hypokalemia.
Correct.
and I think, if, for example, the finances are not an issue, then you probably can consider managing this patient differently. Whether it would have ended with the same, good outcome is difficult to say, because, retrospectoscope is not available for all of us all the time. So, but certainly, because the patient was not septic and the fistula output was low, we could potentially consider, if at all, elemental diet was possible, and then maybe at 6 weeks could have reassessed the situation. Otherwise, managed very well, financial issues notwithstanding.
Sir,
totally agree with that. Yes, Niranjan.
Yes, sir. I agree with Ravi Shankar, sir. It was well managed, and probably I don't think conservative management would have worked in this patient, because there were already 3 holes, and I don't know whether they would have healed with elemental nutrition or anything. Probably it was a good choice to go ahead with surgery.
Yeah, you probably missed that part of my presentation. There's only one hole. The other
One
two
hole,
holes,
okay.
yeah, the other 2 holes were leaking from a subcutaneous tract, not
Okay.
from 2 separate holes from the bowel. Yeah, that's but
Okay.
yeah. Go on. Yeah.
Yeah, sir. I agree.
Yeah. Questions and doubts.
Yeah, I think the students have to note that the issues are, as we have already, that there was no underlying disease. That is one important thing. There is no distal obstruction. The second important thing, nutrition has been taken care of, and then there is no sepsis. So with these 4 caveats being satisfied, only then you can go for the conservative treatment.
Okay, questions, doubts, comments from the students.
Sir, my question, as I've asked in the middle, but it was not cleared, sir. Role of nasogastric tube in managing intracutaneous fistula, sir.
You mean nasogastric tube feeding?
Active aspiration of gastric? No, not for feeding, sir. For active aspiration, will it help?
No role. Absolutely no role. NG tube is very uncomfortable to the patient. You cannot have it in place for days or weeks on end. It causes absolute damage, havoc in the stomach. No role for nasogastric feed for aspiration. There is a role for nasogastric tube for feeding. It's not the regular NG tube, but a soft silastic feeding tube, which you may use to give them elemental diet, particularly in distal ileal fistulas. It doesn't work for proximal jejunal fistulas, but distal ileal fistulas, you can use tube feeding.
Another important, if I may, sir.
Please.
Another important aspect, I think, which I think sir probably has managed very well, is the psychological aspect of a long-standing complication problem. So first important thing all of you kindly note is to not say anything derogatory about the previous surgery or the previous surgeon, because that unfortunately not only brings about bad blood between the previous surgeon and you, and also patient, and also the patients are not idiots. They will still realize that if you can comment badly about some other person, then it will cast aspersions on your character as well. So kindly resist from talking anything derogatory or even negative about previous what has happened. And also, I think it is your role to now prep up their, give good pep talks and improve their morale, improve their, outlook, and say things will get better. Don't worry. So that, patient will cooperate with you. A patient who has trust in you will certainly do better than person who is down also. So I think that psychological component is also extremely important.
Very important. All right. If there are no other questions, what I have now learned from this class is that we must have another ward rounds for anastomotic leaks. All right. We'll have a discussion on some day. Sorry, Sanya, your hand is up. Oh,
yes, sir.
Not hand up. It's a compliment. Thank you. Okay. So, yeah, we will end the class here, and sometime maybe, do you want to do this in October, or you want perianal disease?
So we'll go ahead with this only, so that it can be a continuation.
All right.
Perineal
So
disease
5th,
maybe in
5th October, please read up about anastomotic leaks. Read up about it, and we will talk about the causes, diagnosis, and management of anastomotic leaks. It will be a discussion, not a didactic lecture.
Okay.
Okay, and I'll come up with evidence-based information about anastomotic leaks. Okay, thank you and good night. I'll end the meeting now.
Thank you.